en mode discrétion.
Okay. So hello everyone on the phone lines, and welcome to Part 2, Oral Assessment in Long-Term Care, Unhealthy Changes and Common Abnormalities. So some quick webinar basics. The phone lines have been muted until the end of the presentation, at which time they'll be unmuted, or you can press *6 to unmute yourself, and you can ask questions at that time. Please note that there's a questions and answers or Q&A box that is being monitored by my co-lead of the Oral Care Community of Practice, which is Heather Woodbeck, the Long-Term Care Best Practice Coordinator who works in the Northwest LHIN. If you have any questions or difficulties throughout, please type it into the Q&A panel, and the questions will be monitored. And if there's any questions about the content, type them as well throughout, and we'll address them at the end. To expand to the full screen mode, click on the full screen icon in the bottom left corner. And I'd suggest that everybody do this just so you can get the full benefit of all the oral pictures, which Heather would say the gruesome oral pictures. So I'm Eva McDonald, the Long-Term Care Best Practice Coordinator, and I work in the Champlain LHIN. I'm very pleased to have Tanya Peachman-Faust again with us. So she's a dental hygienist, a certified GPA coach, on faculty at Algonquin College in the dental hygiene program. And she has her own dental hygiene business that specializes in providing services to residents in long-term care. So her wealth of knowledge and expertise is greatly appreciated. And thank you very much for being here again, Tanya.
Thanks for having me.
I also wanted to just acknowledge that her students this year did assist with enhancing this presentation from last year's version. So Brittany O'Neill and Caleb McDonald will be narrating a few of the slides. So this three-part oral assessment series is based on the Oral Health Nursing Assessment and Interventions Best Practice Guideline. So there's three parts. So 2 weeks ago, we focused on the normal mouth. Today, we're going to discuss common and the healthy changes and abnormalities that you might notice. And we'll finish off the series in January discussing interventions that can be done for these changes and when referral is required. So all three of these webinars will be made into an e-learning module after the last session in January, so more information on that will follow. So during today's presentation, we'll be including a quick review of what normal is for each part of the oral cavity, and then we'll describe each unique change and abnormality in more detail and how they would appear and what are some possible causes.
Always begin your oral assessment with the least invasive area and finish off with the area which is most intrusive. Begin with the lips. Look at the outer surfaces and then gently pull them back and look at the inner surfaces. Assess the gums and teeth next, and also the level of oral debris, examining the cleanliness. Run your pointer finger along the gums and the teeth, applying slight pressure. This will allow you to assess for loose teeth as well as any signs of pain. Pull back the cheeks and have a good look at the tissues on the inside of the inner cheek surface. Have the resident open their mouth. Assess the inner surfaces of their teeth, the tops of the tongue, and the roof of the mouth. Finally, inspect the sides and underneath the tongue. As mentioned in previous sessions, this is the most common area of the mouth for oral cancer to be found. This is also the area where you may encounter the most resistance.
So it's very important to use a standard approach to assessing the oral cavity as described by Tanya just now, as well as using a standardized and validated assessment tool to record your findings so that changes can be tracked over time. So here's an example of such a tool, which is the OHAT, or the Oral Health Assessment Tool. So during today's presentation, we'll really be focusing on looking at these categories inside the mouth and looking at the scoring categories of 1 for change and 2 for unhealthy.
Normal lips should appear pink and moist to slightly dry. Some common changes that can occur in the lips would include cracked or fissured lips, which would be because of dryness, and angular-cheilitis, which is dryness at the corners of the mouth. Common abnormalities include canker sores, which can cause discomfort when touched, and cold sores, which are highly contagious and should be avoided when treating the client. So cracked or fissured lips are common findings in a lot of clients. They can be caused by recurrent mouth breathing in the client, or they could just be caused by certain medications. If cracked or fissured lips are happening a lot, then it might be a sign the client is having difficulty breathing through the nose and have to breathe through the mouth more. Cracked lips will appear dry with shallow, steep cracks in them, which, if left untreated, might bleed. Some causes of cracked or fissured lips could include just dry weather, cold weather, or them just licking their lips too much. And if left untreated, though, they could become painful and infected.
Caleb referred to medications as a cause of dry lips. With an increase in medication to treat any systemic illnesses, the outcome is often dry mouth, which can increase the habit of licking the lips and most certainly result in dry, cracked lips.
So now we're going to talk a bit more in depth about what is angular cheilitis. So angular cheilitis is an inflammation and irritation of the corners of the mouth. Angular cheilitis is commonly seen in elderly folks and will appear as dryness at the corners of the mouth and may be painful and cause difficulty eating, as opening the mouth will cause them pain. Now, the cause of angular cheilitis may be a deficiency in the B-complex vitamins or an overgrowth of yeast. Now, turning to the third picture, we see that angular cheilitis initially appears as chapped lips at the corners of the mouth, but it will quickly progress into red lesions, similar to what's seen in picture 1.
What are canker sores? Canker sores are another form or name for aphthous ulcers. They appear as white lesions surrounded by a red halo. Canker sores can be very painful and often cause difficulty in eating. They can appear on the lips, but are also seen in other areas of the mouth. There are a few causes of canker sores, some of which include injury, food sensitivity, stress, or a weakened immune system. Canker sores are not contagious, but when they reoccur frequently, further investigation is required.
What are cold sores? Cold sores appear as clusters of multiple fluid-filled vesicles that eventually rupture, leaving ulcers. These ulcers become crusty in the late stages and can be very painful for clients. The causes of cold sores is herpes simplex virus 1. It is important to note that cold sores are very contagious and easily spread to other areas of the mouth or to other individuals. Any sore in the mouth should resolve within a week, and if it does not, then it requires further investigation. Now we'll move on to the tongue section. Normal findings of the tongue include pink color, facial pigmentation, taste buds of various sizes, fissures, and scalloping on the outer borders. Common changes include a coated tongue with a different level of severity. Common abnormalities include candidiasis and glossitis.
Although fissures of the tongue are a common finding, this should be noted and assessed for changes on an ongoing basis.
A coated tongue will appear with a white substance on the surface that can be brushed or wiped off. A coated tongue is a major cause of bad breath. The cause of a coated tongue is a mixture of bacteria with dead cells that accumulate and get stuck between the taste buds on the tongue.
For residents with fissured tongues, it is important to assess for cleanliness. Debris which coats the tongue can remain within the fissures, particularly with dry mouth, and can lead to inflammation or infection. This would require intervention.
Candidiasis will appear as a thick white substance coated on the tongue that cannot be wiped off. It may be accompanied by red patches on the tongue as well. The cause of candidiasis is an overgrowth of yeast that can cause this infection. It is a very common oral manifestation of antibiotics because the yeast have an opportunity to thrive when less bacteria are present. Glossitis will appear as a smooth, swollen red tongue. It is often painful. Glossitis can be caused by dry mouth, trauma, low iron levels, some systemic diseases, and allergic reactions.
Healthy gums should appear pink, firm, and moist in all areas of the mouth. Some common changes that you might notice are irritation, stomatitis, and swollen gums. These, if left to progress, will certainly lead to gingivitis, oral infection, discomfort, as well as periodontal disease, and perhaps an abscess, which are common abnormalities.
On the following slide, we can see what swollen gums look like. On the picture on the left, we see a comparison between normal healthy gum tissue, which is firm and pink, as previously discussed, and red swollen gum tissue, which indicates presence of disease. On the right-hand side is a real-life picture of what swollen gums look like. The gums all along the bottom of the teeth are red, poofy, and swollen, and would bleed upon touching. This is a very strong indication of disease.
Depending on how severe the gingivitis is, it can make the gums appear red, shiny, inflamed, bleeding, or tender. These signs may vary depending on the severity of the gingivitis. In the first picture, there's a picture of someone with mild gingivitis. gums around the teeth are slightly red and inflamed. There isn't a significant amount of plaque on the teeth, but because the gums are red, it's apparent that there is some plaque under the gums. The second image is someone with moderate gingivitis. As you see in this photo, there's a significant amount of plaque around the teeth and gums. The gums are extremely shiny, inflamed, and red, and bleeding will occur while flossing or brushing the rest of the teeth. In the third picture is a photo of someone with severe gingivitis. The gums are extremely inflamed and puffy. The person's gums probably are very sore and tender to touch. While brushing and flossing this person's teeth, there will be a significant amount of bleeding. Now, in dental hygiene, we refer to rashes of the mouth as irritations. Stomatitis is a very broad term for these, and they can affect almost anywhere in the oral cavity. Now, the typical spots for this to occur, though, would be the roof of the mouth. It is either caused by local infection, systemic disease, or physical or chemical irritant. It is the usual part of the aging process and occurs more likely if they have ill-fitting dentures. Stomatitis may be asymptomatic. Oral patients may complain of bad breath, slight bleeding, and swelling in the involved area, or burning sensation. In mild stomatitis, it can be identified visually as some small red and white pronounced spots that are not normal. In moderate stomatitis, red, puffy irritation and inflammation that is unhealthy is visible, while we still see some pink that is remaining in healthy tissue. In severe stomatitis, all of the tissues of the palate are red or a variation of red. So periodontitis can appear in many different ways. It could be red to purplish gums, swollen or tender gums, bleeding gums, shrinking gum lines, and longer appearing or noticeably loose teeth. Mild periodontitis can be very hard to detect sometimes, as the recession that is present or gum loss that is present is only very slight. The bleeding and inflammation in the gums at this point is very slight, so it's also hard to detect. In moderate periodontitis, there's much variance from person to person that has it. Gums could look uneven or bumpy. Sometimes the gums can look pink and healthy, but they'll be at much lower than they should be and will have already lost some of those gum levels they should be at. There may also be spaces between the teeth and the roots, and the teeth are going to start to be getting loose at this point. In severe periodontitis, there is apparent bone loss and there will be some loose tooth. Also, the gums will appear smooth and shiny, and they will likely bleed easily. And almost all the roots are very visible at this point, which represents severe gum tissue and bone loss. So an abscess will appear swollen, red, filled with pus, and could be painful. So in the first picture, we have a mild abscess. So it's a small abscess with slight redness around it and a clear white center. In the second image, we have moderate abscess. In a moderate abscess, the pus is very obvious and inflammation or redness around the area will occur. At this point, the resident will most likely be in pain. In 3, we have a severe abscess. The abscess will appear extremely large and swollen. In image 4, the swelling will be visible on the outside of the patient's mouth, and the symmetry of the resident's face/neck will be different.
Please note that this last image shows a very advanced abscess infection. This is not common, but clearly gives you a visual of the asymmetry that can occur.
Next, we're going to be talking about the mucosa and saliva. So normal amounts of saliva in the mouth will give the appearance of wet and pink tissues. Saliva normally has a watery consistency. Dry mouth occurs when there is reduced salivary flow. This is considered abnormal dry mouth, as very uncommon. This occurs when a resident's immune system is compromised, or they are taking medication that can cause them to have dry mouth as a side effect. Dry mouth may also be known as xerostomia. In image 1, we have mild dry mouth. There is still saliva present, but there are certain tissues that have a glossy appearance from being dry. The tongue will also appear glossy and will have a slight presence of white coating. In image number 2, we have moderate dry mouth. Saliva will be thick and have a stringy appearance. A white coating will appear on the tongue, cheeks, and gums. In number 3, we have severe dry mouth. There is no saliva present in severe dry mouth, and the tissues and the tongue will have a dry appearance and be shiny and red from the lack of hydration. So now we're going to move into the teeth section. When teeth appear normal, they are even in color, can have visible roots, wear, and restoration. Common problems occurring with teeth include broken teeth, loose teeth, cavities. The image provides an example of what teeth might look like when they are normal. Broken or cracked teeth might not be noticed, but they will appear as different sizes than the other teeth that are like them. On a cracked tooth, there may be a brown line down the middle indicating that it is cracked. Broken or cracked teeth are more common in seniors as teeth wear with time. Aging teeth have a smaller nerve and smaller blood supply, which makes them weaker and more prone to cracking or breaking. Other causes of broken or cracked teeth can be a result of weakened tooth structure. due to things like trauma, decay, old fillings not fitting correctly and doing damage to other teeth, or them biting down on something too hard. Sometimes cracks can be hard to see, like a hairline fracture, and sometimes teeth are so broken that they can only be seen at the gum line.
It is important to note that one of the most common reasons for teeth breaking off at the gum line in residents is due to root caries. Caleb will address this in slide 27.
Cannot usually not lose tooth unless the person is eating, talking, or if the resident pushes on with their tongue. There are several factors which can contribute to loose teeth. It could be gum disease leading to bone loss, which would make the teeth loose because there's no supporting bone holding in their place. It could be from trauma, such as a fall, or it could be from grinding their teeth too much, which wears down the teeth and could hurt the nerves below. Dental cavities are the destruction of tooth structure due to bacteria and plaque. Bacteria in the tooth break down food and produce acid that destroys the tooth structure, resulting in a hole in the tooth called dental caries, also known as a cavity. Arrested caries occur when the destructive process is halted and the cavity does not need to be restored. Arrested caries appear as a brown-black stain on the tooth. A common area for decay in seniors is along gum line. As the gums start to shrink, the roots are exposed. The roots are not as well protected as the top part of the teeth, so they are more prone to decay. Some contributing factors to the formation of cavities include diet high in sugar and starch, poor oral hygiene, and dry mouth.
Now you may be wondering, what does tooth decay actually look like? The following three photos are pictures of different stages of decay. Early decay can present as white chalky areas on the teeth, as seen in the photo on the left. More advanced decay can present as black or brown areas on the tooth, or even may appear as a slight shadow on the tooth. Lastly, and in the most extreme cases, decay can present as black or brown holes within the teeth.
So normal dentures should appear smooth, have no staining or debris, and should be labeled. So it's really important to check regularly to ensure that they remain labeled. Problems with dentures are due to poor fit and can affect oral tissues and can result in stomatitis and ulcers, which we discussed under the gum section, and they can also result in overgrowth from not being removed. So the picture on the left shows overgrowth. Lastly, look at the dentures themselves to ensure that they're not broken or cracked or warped, and that any liners that may have been placed on them remain securely attached.
Plaque is a mixture of food debris and bacteria that builds up in the mouth and it can be wiped off by toothbrushing. It's not normal for there to be abundant amount of debris in the mouth. If the buildup persists, it'll form tartar. And if tartar persists, it can form decay, which will lead to cavities. So for the first picture, we showed mild debris. On the second, we showed moderate debris. On the third, we showed severe debris. And on the fourth, tartar.
Malodor or bad breath is an immediate sign for further investigation. Whether you notice the bad breath from a distance or up close, this should not be occurring. The most common cause of malodor, is oral infection or high levels of oral debris left in place for a long period of time. During oral assessment, please ensure that you are observing for any physical signs of pain or verbal complaints from the resident.
Carcinoma may present as a single persistent ulcer, red or white lesion, lump or fissure. Also, the lesions may present anywhere in the mouth, including the outside and around the lips. Usually the lesions are chronic with raised, rolled edge around it. If there is a lesion that does not heal after a couple of weeks and looks suspicious, please document and get a referral done. Next, we're going to be talking about oral cancers. So it's extremely important to check all of the oral cavity for oral cancer, as it shows the multiple areas as seen in the picture. Areas to check include the upper and lower lips and gums, inside of the cheeks, the lower lips and gums, the roof of the mouth, the back of the tongue, and underneath the tongue and the sides of the tongue. The most common areas for cancerous lesions to develop are the sides and underneath of the tongue.
So it's important to remember to do a daily oral cavity assessment, either during care or when feeding residents, so that you can pick up on any changes and abnormalities quickly. So the last part to this series, and we're going to talk about interventions, is on January 13th. So here's the little link so that you can register. We've also included a couple of resources that can help you. So again, we've included the best practice guideline itself, as well as the link to the toolkit, and there's an oral health section with many awesome resources. Then there's also the Halton Oral Health for Seniors website. And so this includes information on common oral health conditions in seniors, as well as some multiple PDF presentations that you can use to support oral health education for your staff. And finally, there's the pocket dockets. So here's just an example of what it looks like. And these are little cards that staff can put in their pocket just as reminders for the steps for how to complete oral care and how to do denture care. So just once again, I want to thank Tanya for her help with this series, as well as her students who helped to update it. So their names are just listed here. And so this brings us to the end of the presentation. So I want to thank everybody and hope that you have a better understanding of the transitions from healthy oral health status to things that are unhealthy. And just ensure that if you do see any changes, that you are reporting it to registered staff. So I will unmute all the phone lines now, but I will also put up a poll, so if you wouldn't mind completing that, that would be wonderful.
The conference has been unmuted. Le mode discrétion a été enlevé de la conférence.
Oh, we have one question. Hear me, Evo?
Yes, I can. Go ahead.
Good. So where are the resources available from?
Oh.
There's toolkit, right?
Yeah. The links are right there. So if you're referring to the resources I just discussed, the links are there provided. And they're free of charge. You just have to go on and get it.
Yeah. Good. And so someone can also just RNAO long-term care resource toolkit. That's the one that we've just revised, and so there's an oral care section, and it's on there too. I think that's the address right there.
Yeah, it is.
Sorry. Yes. That's aware though.
So are there any other questions? You can either ask them over the phone, everybody's been unmuted, or you can just type them into the question box.
Should dentures be soaked in or out of water at night?
Dentures should always be in a moist environment. They should never be left to dry out. So they should stay in a cup of water or an antibacterial soak overnight.
Really?
Yes. Yes, absolutely.
Okay, so if someone's choosing not to wear their dentures, what's the best way to store them then?
In a moist environment.
Okay.
Mm-hmm.
We need a face paint. Oh, don't even go there. Oh, Now, there's another question. I don't quite understand it. From Leonie, can you send us this topic, please? I'm not sure what you're asking, Leonie.
I just want to get where you get the resources so that we can get more information.
Okay, yeah.
Okay, thank you.
Yeah, that's this. RNAO has we revised our long-term care resource toolkit.
Okay, then.
Yeah, if you go onto your computer and just put in Google LTC or RNAO LTC resource.
Okay.
Yeah.
Okay.
Right.
Thank you.
Good. What else? I don't have any more questions coming from here.
Okay. Anybody else on the phone lines? Well, we'll just wait around for another minute in case anybody thinks of anything. Otherwise, thank you so much for everybody who participated, and I hope that you were able to learn a little bit more about oral health. And thanks so much for Tanya for coming and being present as always.
Thanks for having me.
And thanks, Heather, for moderating.
Thanks, Heather.
You're welcome. We'll have to meet in person sometime.
Yeah. Someday. It's on my list.
I'm getting a beep.
you.